Tvang ikke nødvendig overfor mennesker med alvorlige psykiske lidelser når behandlingen god, sa psykiateren Richard Warner. Han var invitert av Erfaringskompetanse i forbindelse med lanseringen av publikasjonene Alternativer til tvang. Professoren i psykiatri ved Universitetet i Colorado fortalte blant annet om et godt etablert lavterskeltilbud hvor tvang ikke brukes som et alternativ til sykehusinnleggelse.
My work has been devoted almost entirely to working with people with serious mental illness and finding ways to help them get through that experience and then get on with their lives and have real lives that mean something to them and to other people. And a lot of that work has in fact involved fighting the problem of coercion that exists in the field that we are devoted to. It's a special burden for psychiatry that not only do we have to treat people and do no harm, but also we have to protect them from lapses in judgment, and we have to protect them from other people in the community from any lapses in judgment that may emerge from these very serious mental illnesses that we have to treat. And amongst these forms of coercion, I'll be talking initially about seclusion and restraint. What are the negative effects that come from these forms of coercion in inpatient hospital units? How often are they used? And what's happened recently in the United States is a dramatic reduction in the use of those measures, and I want to talk about how that's happened. I want to talk about how everybody can make it happen. And finally, I want to talk some at the end about alternatives to hospital in order to provide the same kind of treatment, but in a non-coercive, more human kind of setting. So the story starts more than 200 years ago with the era of moral treatment. And here you see Pinel casting the chains from the inmates of the Bicêtre asylum in France. And that's part of the story. It's one of the values that emerged from moral treatment era in the late 1700s. Another one is what will be the latter part of my talk, the creation of alternatives to the asylum for treating people who have serious mental illness. And this is a picture of the York Retreat, which was developed in the late 1700s by Quakers in Great Britain as an alternative to the York Asylum, where they witnessed the most horrendous forms of treatment. This was the point in history where we stopped treating people who were suffering from serious mental illness as if they were animals and began to treat them as if they were human beings. And from that phase of our history has emerged a set of values which sometimes we lose, sometimes we regain, with different kinds of social movements in psychiatry. Unfortunately, at this point in our history with the recovery movement, we're recognizing again some of these values that are more than 200 years old, and reduction of coercion is one of those. Now, in the alternative that the Quakers created, the York Retreat, they created a place which was described as a visitor from Switzerland as a house situated a mile from York in the midst of a fertile and smiling countryside. It's not the idea of a prison that it suggests, but rather that of a large farm. It's surrounded by a great walled garden, no bars, no grills on the windows. So here you have a domestic setting lacking in coercion, which is the point that we'll get to. But right now I want to talk some about how we can reduce the use of seclusion and restraint inside hospitals. And so here are the definitions. Seclusion is when somebody's confined involuntarily to a room which is locked. And restraint is the application of direct force, human or mechanical, to restrict someone's freedom of movement. Now, I put this definition in largely because in Britain, many practitioners will say, well, we don't use restraints. Well, it's true. In Britain, for 100 years, they haven't used mechanical restraints, but they do restrain people by physical, human means. And so it's important for us to recognize that any form of holding somebody down, whether it's with leather straps or by several people holding you down, is nevertheless a form of coercion, which is very unpleasant. In fact, seclusion and restraint can lead to subjective experiences of anger, of fear, of humiliation, and of course of a negative attitude towards treatment. And back in 1976 in the United States, when the use of restraints and seclusion was very common, people would describe that seclusion room experience as being horrendous and something that colored their entire experience of mental illness. So mental illness wasn't experienced necessarily something awful in itself. It was the treatment that was provided at that time which became the worst part of it for many people. In 1998, you'll see that the newspaper in Connecticut listed over 140 deaths due to the use of restraints or seclusion in the previous decade. And the National Alliance of Mental Illness, which is an organization of families and friends of people with serious mental illness in the United States, issued a report of deaths, abuse, and neglect due to restraints and seclusion. Now, since that time, there's been a dramatic decrease or change in the use of restraints and seclusion, and it's reflected in the attitudes that are evident in the that are taken towards the use of restraints. So back in 1978, when the use was very, very common in US hospitals, the reasons that somebody might be put in restraints is non-conformity to community rules. That means the rules of the hospital unit, and behavior disruptive to the therapeutic environment. So it meant essentially that if you shouted, if you swore at a nurse, if you were complaining too much, you could be put into restraints. Now, there's a very different standard. Restraint and seclusion are to be used only in an emergency and when there is imminent risk of an individual physically harming himself or others. So what's brought about this dramatic change? Well, as a result of pressure from an advocacy group, which was essentially the National Alliance on Mental Illness, approaching government officials, there was a new federal governmental rule which came down to all the hospitals across the country, saying that if a doctor ordered somebody to go into restraints or seclusion, that doctor had to come and see the patient within 1 hour, regardless of the day or night. Now, this had a very dramatic impact, as you can imagine. All the practitioners at home in their beds, they might be woken up by a nurse previously, and they'd say, so-and-so is doing such and such, we want an order for restraints. The doctor would give it, and he'd go back to sleep, or she'd go back to sleep. That wasn't going to happen anymore. And so suddenly, there was a realization that things had to change and that restraints had to be used a lot less frequently. That did happen. And the other thing that happened is that the practice of inpatient psychiatry changed dramatically, and instead of there being private practitioners, maybe a dozen of them treating patients in the same hospital, now there would be a staff of devoted hospital psychiatrists who are only doing inpatient work, so that they could, because the private doctors didn't want to run the risk that they'd be called up in the middle of the night or in the middle of the day when they're seeing their outpatients and be required to come to the hospital and see a patient. So things changed very dramatically. How did they change? Well, let's see. I'll have to come to how they changed. I just want to show you how the how the frequency of use of coercion varies greatly across European countries. This is a study of 10 countries, and you'll see that of patients involuntarily admitted to hospital, some coercive measures, and I'll be talking about in a moment what coercive measures those were, occur with dramatically different frequency. So there's a 3 times difference between Spain and Poland in the frequency with which coercion is used for involuntarily admitted patients. Now that says to any and all of us here that means this is something that can be changed, and it's not something which is just necessary. It's something which depends on practices in individual locations, or in this case in different countries. Now there are 3 coercive measures being talked about in this research. I'm going to tell you what they are, and then I'm going to ask you to put your hand up for the one which you'd least like to be subjected to. So first one is being subjected to the involuntary administration of medicine by injection, forced medication. No, not yet. I know you. You know which one you hate. The second one is being strapped down with leather straps to your bed for maybe some hours, maybe less than an hour, but often for some hours, so that you can't move. And the third is being locked in a seclusion room on your own, but not strapped down. So everybody understands what those 3 measures are? So who thinks that being injected with medications forcibly in order to essentially restrain you by injecting you with sedating medicines, who thinks that would be the worst that could happen? Who thinks that being strapped down with leather straps would be the worst? And who thinks that being locked in a room on your own for any length of time would be the worst? So it looks like forced medication would be the most unpopular, and seclusion would be the least unpopular. And here are what they found. In some countries, forced medication is used as the primary measure, and the difference is, again, something like 2 to 3 times more frequent in Sweden than in Greece. Restraints are very commonly used, but more so where the use of forced medication is less. But then strangely, there are some countries where there's no use of seclusion, even though that's what many people here would prefer to be used. So instead of using seclusion, some people are being strapped down to their beds instead of just being put in an isolation room on their own. So clearly some could change some practices here. There's no reasonable explanation for why some hospital units wouldn't use seclusion, except the fact they may be very short of space and not have empty rooms. So let's just move on. All I'm saying is there's room for change and improvement everywhere. So what was the effect in the United States? When this measure was brought in that I described, this 1-hour rule, in an 8-state trial of training to reduce the use of restraints and seclusion in the early years of this century, the 68% fewer restraints or seclusion events resulted from that training. And in a child hospital, you can imagine children being strapped down with restraints, the reduction there was 97% in the use of restraints, from 263 occasions in one hospital in a year to 7 in a year. Looks like there was room for change there. Again, in an 86-bed state hospital in Texas, a 94% reduction in restraints and seclusion over the course of a few years. In 2 crisis centers, where people are coming in acutely disturbed before going on to the hospital, the crisis centers achieved a 0 level of restraint use within 1 to 2.5 years, with a decrease in staff injuries. So the concern that many staff would have had that reducing the use of coercive measures would increase staff injuries was not borne out. Now, here are the things that the US discovered and other people have discovered in the course of trying to reduce inpatient coercion. You need various things to happen. Supportive leadership, proper staffing levels, that doesn't mean more staff. The extra expense goes on staff training and support, not on staffing numbers. Various environmental factors that I'll touch on, individualized treatment plans, effective communication with patients, and debriefing after episodes of seclusion and restraint for both the staff and the patient. I will not talk about these things in great detail because I'm limited by time. I will go on to say that the supportive leadership is absolutely fundamental. The change has to come, perhaps from government initially, to the hospital administrators, to the people working in the unit, including the psychiatrists. There has to be a switch from trying to control patients as external agents to partnering with them in their own care. Patients have to be participants in their own care, and physicians have to be included as members of the team that are working together with the rest of the staff to reduce the coercion. The cultural environment has to change so that you only use seclusion and restraints when you absolutely have to. Staff have to be able to tolerate the expression of anger. Staff have to be out on the unit all the time with the clients, not just hiding away in the nursing station. There has to be a right balance of activities, socialization, rest periods, so you can have both a productive and a recreational life on the unit. Rules have to be reasonable and not just institutional mandates. And patients need to be offered choices in what to do if they start to get agitated. And if somebody does begin to get agitated, what do? Staff try to have a discussion about what's going on. How come you're feeling this way? Tell me more about it. How about trying some deep breathing, or would you like to take a shower, or want to use the exercise bicycle? Sit down and have a talk with me and explain to me where you're coming from. Would you like some privacy in your room? Or would you like to take some medicine that might help you calm down? Those kinds of measures are choices that can be offered. The physical environment is important. I'm going to describe a couple of examples of that. I remember being shown a day center, which is like a club for people with serious mental illness in a city in northern Italy. Very comfortable, like being out in the lobby here with tables and chairs and sofas and books to read and paintings on the wall and windows to look out of. And then they showed me the inpatient unit, which was the opposite of that. There were no pictures, no comfortable furniture, no spaces to sit and relax and talk. It was a corridor with furniture screwed to the floor. The point being that an inpatient unit, they were concerned that people would pick up furniture and throw it, or otherwise be so agitated they'd use objects as weapons. The result, of course, was a barren environment with no opportunity for leading a normal human life. So the kind of physical environment that, in fact, does demonstrate the capacity to reduce the use of coercion and restraints is a comfortable, attractive setting with quiet rooms, with space to move around, with areas to withdraw to, with art and other activities that one can pursue, and with a nursing station that isn't enclosed and cut off from the clients, but open so that people can come and chat over the counter with staff, and staff can come and go and be with the clients. Debriefing, again, is important, as I mentioned before. Staff need to be able to chat, to have a meeting and discuss how did this happen, what led to the problems here, patients included, tell me how we could have done this better, and of course a focus on, did the staff overreact? Were they fearful because the person appeared to be very big and strong, and they stepped in sooner than they needed to? All kinds of discussions that can lead to improvement in the future. So here's an example of a state hospital in the southeastern United States that over the course of 3.5 years introduced changes to reduce coercive events in the hospital and succeeded. And they had 4 measures that they introduced, but in random order in different units in the hospital. So they're able to test out which of these interventions was most effective. So one was training the staff on recognizing how previous trauma, could affect a person so that when exposed to more triggering events could lead to agitation. Training for the staff on how to address people appropriately so that they didn't anger them and irritate them by being too peremptory. Training on involving patients in treatment planning. How do you engage the patient so you plan appropriately to head off any problems with agitation? And enhancing the physical environment of the ward. Now again, I'm going to ask you to look at these, and then I'll read them out, and I want you to hold up your hand for the one you think is most likely to have been associated with a reduction in coercion in the units. Training on the effect of trauma for patients. No votes. Training on the effect of the language you use in talking to people out on the unit as nurses. Several votes on that. Whoa, a lot. Training on involving patients in treatment planning. And enhancing the physical environment of the ward. Now, some people here heard me talk earlier in the day, so they know that the correct answer, the actual answer, is that the enhancement in the physical environment was the one factor that produced the big impact. And the reason is that there's a message that comes out of the physical environment. If all the furniture is screwed to the floor, then the message is, you're very dangerous and you're going to throw something at me. I saw another unit in Australia where the outdoor space was essentially like a prison yard with very high walls, very narrow space, dirt or sand on the ground, no vegetation, no flowers, very narrow space. And inside, the staff were completely blocked off with glass walls from the patients. And when I went in there, the head nurse said to me, listen, they've brought you in here to consult because we've had so many assaults. Shall I tell you how to cut that down? Take down these walls around the nurses' station. So essentially what you had there was a prison environment, and the message was, attack these guards. It's very, very important how you set up the internal space in an inpatient unit. I'm running out of time probably, so here's the sorts of things they did in that study to improve the physical environment: repainting with warm colors, putting in rugs and plants. You can throw plants at people, but you can put them in there and people don't throw them. So, replacing old furniture, rearranging furniture to allow people to sit in small groups and talk to one another. regular meetings between the staff and the patients. But all of these changes happened in the context of a leadership focus on reducing coercion and an overall focus on improved staff-patient communication. So I don't want to say that the physical environment's the only thing, but it is a very important aspect. Here's some more. Another study which talks about positive impact comes in the physical environment comes from more private space, higher level of comfort, greater visibility of staff on the ward, and of the staff of the patients being visible from the nurses' station, and also the negative impact from violence-proof safety measures like screwing the furniture to the floor and too many patients in the space and no outdoor space. So now I'm going to spend a few minutes, don't know quite know how many I've got, talking about the thing that whole discussion of physical enhancement of the environment leads on to, which is one can create, and I spent 30 years doing this and running an alternative to a hospital, which was a non-coercive, open-door, house on a street, you see it here, part of the public mental health system in a county for 300,000 inhabitants. We had 600 of our patients had psychotic illness, so we had people coming in and out of hospital all the time. We created this facility here, a 16-bed facility with this kind of domestic environment, but with medical staff, psychiatrists and nurses and mental health workers, which acted as an alternative to hospital for probably 3/4 or more of the people that needed to be in an acute treatment setting. So 15 patients here in this facility. In hospital, usually about 4. So this was a facility that was very effective in treating people with acute episodes of schizophrenia, of depression with psychosis, of bipolar disorder, and it offered exactly what you'd expect in a hospital in terms of medicines prescribed and administered by nursing staff. It was in a mixed residential business neighborhood, so patients could come and go to the coffee shop and to the stores, and when they had passes, they could actually be out in the community pursuing their business and seeing friends. The cost was half that of the hospital, so it was good for the mental health center, and that's one reason we were able to do it for decades. The average length of stay was a couple of weeks or so, but the range was from 1 day to 1 year, so we were able to use it very briefly for people who only needed a brief admission, but for a very long time for people where we couldn't find a satisfactory treatment modality for them when they left. So this was to help them stay stable until we could create a stable community treatment setting. The staffing was 1 nurse on each shift, 1 mental health worker on each shift, and during the daytime 1 team leader, 2.5 therapists, so it means 2 therapists and a half-time therapist, and 1 office manager, half-time psychiatrist, that was me, and a cook who was there half-time. And after hours, there was a full on-call psychiatry service so that people were admitted voluntarily or involuntarily at all hours of the day and night. There are a similar array of these facilities now in Britain called crisis houses, only they're smaller. But like the one that we had in Boulder, which is where I'm from, a large proportion of the patients were compulsory and involuntarily admitted. Why did they stay there? Because the alternative would be being in hospital, and who wants to be in hospital when you can be in a domestic style facility? Very large numbers suffer from psychosis. The staff are awake all through the night, and a similar length of stay in general, a little over a month. So this is a model that's has been picked up in Britain as well as elsewhere in the United States. Here's where I work now, which is a private version of this facility that I worked in with the public service for 30 years. This facility is called Balsam House, and it's part of a large residential and outpatient program. We take people here who are the most disturbed from across the country. We take people who failed in treatment for serious mental illness, for psychosis, from all parts of the country, and they come here. And despite the fact that they're very ill, they do well and they get better. I won't be well, they're showing you the outcomes here, but people end up moving on, having a life, having suffered many of them for a very long time with an illness that wasn't getting better at all. And here are the diagnoses that they suffered from. So that's all I have time for, and thank you very much for your attention.